Hi, my name is Marie-Pierre, and on behalf of our team, I would like to thank the ICS Scientific Committee for the opportunity to present you our study on the effects of physiotherapy treatment on the pelvic floor muscle function and morphology in gynecological cancer survivors with dyspareunia. After breast cancer, gynecological cancers are the most frequent female cancers. The endometrial and cervical cancers having the highest 5-year survival rate. According to epidemiological studies, there is a growing number of survivors, implying that more women could struggle with the consequences of cancer. Surgery, brachytherapy, external beam radiation therapy, and chemotherapy often result in pelvic floor muscle changes that could contribute to the development of pelvic floor disorders, significantly affecting the quality of life of women and their partners. Dyspareunia is a common condition affecting up to 67% of survivors, which is higher than the prevalence in women with no history of cancer. Although dyspareunia affects more than half of survivors, very few evidence-based treatment options are available for this population. Physiotherapy treatment could be effective as it targets pelvic floor muscle alterations such as height and tone, lower flexibility, and coordination and endurance, which were highlighted in survivors with dyspareunia in a recent cross-sectional study. To date, only one prospective interventional study has investigated physiotherapy in this understudied population, and findings reveal significant improvements in pain symptoms and sexual function after physiotherapy. However, it is unknown how this treatment can improve pelvic floor muscle function and morphology in these women. Therefore, the aim of the study was to evaluate the effects of physiotherapy on pelvic floor muscle function and morphology in gynecological cancer survivors suffering from dyspareunia. Data of this study were derived from the prospective study investigating physiotherapy in 31 gynecological cancer survivors with dyspareunia. Women were included if they had completed cancer treatments for at least 3 months and presented vulvovaginal pain of a minimum 5 out of 10 in at least 80% of sexual intercourse for more than 3 months. A standardized pelvic examination was performed by a gynecologic oncologist to confirm the eligibility of participants. Exclusion criteria included, for instance, having vulvovaginal pain before cancer or unprovoked pain, or having other conditions interfering with the study. Women were asked to refrain from using other treatments that could influence outcome measures during their participation. Women underwent baseline and post-treatment assessments with an experienced physiotherapist not involved in the treatment. The following parameters were assessed and showed strong reliability and validity in previous studies. To assess pelvic floor muscle function, the intravaginal dynamometric speculum was used. This instrument measures the forces exerted on the two branches allowing different apertures. Several parameters were assessed: passive resistance at the minimal aperture, tissue flexibility in accordance to the patient tolerance of the stretch to the maximal aperture, maximal strength, coordination, which refers to the number of rapid contractions performed during 15 seconds and the speed of contraction, and finally endurance, which was calculated from a 90-second maintained maximal contraction over a 50-second period. To assess pelvic floor muscle morphology, the transperineal 3-dimensional and 4-dimensional ultrasound imaging was used. The following parameters were assessed: bladder neck position according to the horizontal and vertical position, anorectal angle, levator plate angle, and levatoriatal area, as well as its anterior, posterior, and left-right diameters. Measurements were taken at rest and on maximal contraction. Physiotherapy treatment consisted of 12 weekly 1-hour sessions, including education, pelvic floor muscle exercises with biofeedback, manual therapy such as stretching techniques, in addition to home exercises. All modalities were progressed throughout the treatment. Of the 31 gynecological cancer survivors with dyspareunia, 1 withdrew because of illness in the family and 2 were lost at follow-up. Participants' mean age was 6 years old and the mean body mass index was 29, cancer stages ranged from 1 to 4 and women received different cancer treatments. The median of time since cancer treatments to baseline assessment was approximately 3 years. Significant changes in pelvic floor muscle function were found from baseline to post-treatment. Participants showed a reduction in passive resistance at the minimal aperture, suggesting a reduction in muscle tone, as well as an increase in tissue flexibility and improvements in pelvic floor muscle coordination and endurance. However, the change in maximal strength from baseline was not statistically significant, and this was expected as the physiotherapy treatment emphasized muscle relaxation and control rather than strength training. Regarding pelvic floor muscle morphology, results demonstrated significantly greater anorectal angle, smaller levator plate angle, as well as larger levator atoll dimensions at rest following physiotherapy, suggesting also a reduction in muscle tone. On maximal contraction, the bladder neck was positioned more cranially and ventrally, and a significant decrease in levator atoll area and its anterior-posterior diameter were observed after physiotherapy, suggesting improvements in contractile properties of the pelvic floor muscles. To our knowledge, this is the first study to evaluate the effects of physiotherapy on pelvic floor muscle function and morphology in gynecological cancer survivors with dyspareunia. Findings support the rationale that physiotherapy contributes to improving the pelvic floor muscle function and morphology in this population, which may represent a key treatment mechanism to reduce pain symptoms and even improve sexual function. However, a well-designed randomized controlled trial is needed to confirm these findings. Thank you very much for your attention.